Everyone for the first session on pain management. Today we have as our faculty Dr. Mary Abraham. Ma'am is a neuroanesthetist and with special interest in pain medicine and palliative care. She was trained in palliative care a few years back from Trivandrum, and after that she is working in the field of pain management and palliative care. She worked in various hospitals in Delhi, and she has herself has written a book called Conquering Pain, and she's been with us as the faculty for I think many years now, and all the sessions are really appreciated by the participants. So today we'll be talking about the step 1 and 2 of WHO ladder with adjuvants. So it's a long session because there are a lot of information that will be conveyed to you, so I'm not wasting time. Over to you, ma'am. Ma'am, we can't hear you. No, your microphone is not connected. You are unmuted, but I think your microphone is not. Commonly used in the country, tramadol and tapinaroid, and there are a lot of adjuvant analgesics that we use in palliative care. So we'll be covering a little bit of adjuvant analgesics also in today's session. And she'll be coming again for having a session on difficult pain. So today will be the first session on pain, and the next session we'll be hearing about the step 3 analgesics.
Happened right in the beginning. Am I audible now?
Perfect, ma'am.
Yes, yes.
Okay, then let's start this presentation now. It is, as usual, a pleasure for me to talk to all of you. I believe this is the session on WHO analgesic ladder 1 and 2. And as usual, it is a privilege for me to take this talk. So the broad outline of my talk is, I will be talking on the basics of the WHO analgesics ladder and focusing on step 1 and 2 of the ladder, along with the adjuvant drugs and drugs for neuropathic pain. Now, the WHO analgesic ladder was devised way back over 30 years ago, based on the recommendations of a group of international experts. Okay, their target was how to manage pain, and particularly cancer pain. And subsequent to its introduction in the mid-80s, it has been translated into 22 languages and has served as a catalyst for treating cancer pain worldwide. Now, it is a very simple, well-validated and effective tool, and it's actually a stepwise approach to treat cancer pain depending upon the severity or the intensity of pain. Now, before the ladder, people were dying with unnecessary pain for various reasons. One was because of the drug regulations associated with the use of opioids. It was where there was a lot of bureaucratic process, and prescriptions, special prescriptions had to be written, and there were strict laws that prevailed over the use of opioids because of the fear of abuse and misuse of opioids. So all that was a barrier for people to access opioids. Secondly, there was a stigma associated to taking opioids. People were dubbed as, will I become a pain addict? Or, the people will dub you as a pain addict. And even the doctors were very hesitant to prescribe morphine and narcotics because they were also afraid of the law, the strict laws that prevailed for the use of opioids. But when the WHO introduced this ladder, it actually legitimized the use of opioids in pain management. So it was, after all, authenticated by the WHO. So that became a legitimized the use of opioids in the management of pain. Now, let me start with a case scenario. A 35-year-old father of 2 young kids. He had squamous cell carcinoma in the upper lobe of the right lung. The pain was a deep-seated gnawing pain in the right shoulder with burning and tingling in the right arm. he was unable to sleep. The pain score was NRS 4 during the day, and at night it was 6. So before you handle such patients, we need to do a comprehensive assessment of pain. So there is a mnemonic which is PQRSTU, okay, which will help you in assessing the pain. I think this has been dealt with in a previous session, so I'm not going too much into detail of it. The second important thing we have to do for assessment of pain is to know the type of pain. Is it nociceptive or neuropathic, or is it a combination of the two? Both nociceptive and neuropathic also, both. Now the WHO analgesic, so that is very essential. Assessment of pain is very essential before you apply the ladder. Okay, now what is the ladder? It has basically, the ladder that was introduced was a 3-step ladder. In step 1, it is used to treat mild pain, in which we use a non-opioid analgesic with or without an adjuvant. If this is not controlled with this regime, then you have to move on to step 2, which is basically for moderate pain, where the NRS is varying between, say, 5 to 7. Okay, or if the pain is not controlled with the step 1 drugs, then you add a weak opioid to the non-opioid with or without an adjuvant. Now, despite this, if pain is persisting, then we have to go on to a strong opioid. Replace the weak opioid with a strong opioid, along with a non-opioid and with or without an adjuvant. Sometimes, this is usually for pain scores that vary between 8 to 10, which is very severe pain. Sometimes you can even skip step 1, step 2, maybe directly go on to step 3 also if it's required, if the patient is coming in very, very severe pain, in which you have to do a morphine titration and start off with a strong opioid right in the beginning itself. Now, using this step ladder approach, up to 71 to 76% of cancer patients' pain can be satisfactorily treated. Okay, so that is a good thing. You're giving drugs through the ladder, and you can treat nearly 3/4 of patients with cancer pain. Now, what are the salient features of the ladder? Please remember 3 things. First 3 things is by mouth, by ladder, and by clock. By mouth means all the drugs are given orally. That is a standard route of administration, even for the strong opioids. And because of this, it is very suitable to apply for home care. It can be given by the palliative care doctor, or it can be given, by the visiting doctors or the nurses. It can even be taken by the caregiver of the patient also, because it's all given orally. Now, the second important thing is that it is given by the ladder. That is, in normal course, you start with step 1, and according to the severity of pain, you move up the ladder. And like I said, occasionally you can even start with step 2 or step 3 directly. The third important characteristic of the ladder is all the drugs are given by the clock. By the clock means the drugs are given according to the duration of action or the half-life of the drug. It is not given on a PRN basis. That is, when the pain comes or when there's a breakthrough pain, then you give the drug. This means that you're controlling the pain throughout. There are no peaks and valleys. So the patient also is more satisfied when the pain is under control 24 hours of the day. And that can be achieved only when you give it according to the duration of action of the drug. To make it clear, if I'm giving morphine to a patient, we know that the half-life of morphine is 4 hours. So every 4 hours, you have to give the next dose of morphine. So you have to tell that very clearly to the patient that if he's starting at 6 o'clock, the next dose is due at 10, then at 2, then at 6, and then at 10. So you have to tell them to go by the clock. That depends upon various drugs. It could be 6 hourly, 8 hourly, 12 hourly, all depends upon the half-life of the drug. So this prevents the breakthrough pain happening. Another important characteristic is that it is individualized to the patient. The right dose of analgesic is the one that is causing relief of pain. It can vary from patient to patient. For example, there is a patient whose pain is controlled with 30 milligrams of morphine. In another patient, it may be controlled with 120 mg of morphine. It all depends upon the pain the patient is having, how severe is the cancer, and how the individual characteristics of the patient also. Okay, so that is very important, that you have to individualize the regime so that there is total relief of pain. There is good relief of pain during the whole 24 hours and no breakthrough pain will happen. Also, you have to tell that even in this 4 hours, if pain occurs, and what do you have to do? That is a treatment of breakthrough pain. That all have to be specified to the patient. That is why we say that you have to individualize it to the patient. Then we can use an adjuvant drug at every step of the ladder. This is used for specific types of pain and also to decrease the undesirable side effects of the analgesics. For example, if you are giving a neuropathic, if there's a neuropathic pain, then you may have to add a drug for treating neuropathic pain, or if there's a bone pain. So the adjuvant drugs can be added at every step of the ladder. And very important is attention to detail. So attention to detail is you have to take into consideration the patient's age, the body weight of the patient, the comorbidities that the patient is having. Does he have a kidney dysfunction or a liver dysfunction or any allergic history of any allergy or any drug interaction? So the drug history of the patient has to be taken, kept in mind. So many things have to be has to be detailed. Meticulously, you have to look at all that. Now, what are the advantages of the WHO ladder? First of all, we know based on what you have seen, simple and easily understandable. And it is a validated tool. That means it has been found to be effective if you use it in the way it is supposed to be. And also, all the drugs of the ladder are very cost effective, relatively inexpensive. So it is not working out very expensive to the patient. It can be implemented across the world, even in underdeveloped countries. And it is well suited for home care because most of the drugs are given orally. And it is, I've explained all the things, you can monitor it. And besides cancer pain, you can also use it for any kind of acute pain. Like, for example, post-operative pain or pain due to trauma or fractures, that you can also apply the WHO ladder. We can use it also for chronic non-cancer pain as well. Now, there are certain modifications of the ladder. Sometimes, instead of omitting, you can omit one step, like instead of going on to step 1 and step 2, you can directly go from step 1 to step 3. These kind of modifications can be done depending upon the patient response. And then you can even add a 4th step, particularly for treating crisis of chronic pain or refractory pain or difficult pain that is not responding even to the strong opioids. So this was a modification of the WHO analgesic ladder in 2000, basically for patients with intractable pain, which were not controlled with the strong opioids. So in that 4th step, you can do various interventions like nerve blocks or epidural injections or patient-controlled analgesia pumps, or you can give a neurolytic block, for example, a celiac plexus block or a superior hypogastric block. You can use a spinal cord stimulation, or even intrathecal opioids can be given. So this is in those 10 to 15% of patients that are not responding to the 3-step ladder, you can add a pain intervention as well. Now let's discuss step 1 drugs. Step 1 drugs are the non-opioid drugs like paracetamol, non-steroidal anti-inflammatory drugs, and they can be combined with an adjuvant drug. Now, paracetamol is a word that is used in India and Europe. In US, it is called acetaminophen. They are the official names of the same compound. It has a predominant central action. That is, it acts on the central nervous system. It inhibits the enzyme cyclooxygenase in the central nervous system. It does not have an effect on peripheral cyclooxygenase enzymes. And because of that, it has less side effects. It has predominantly an antipyretic analgesic action, but it does not have any anti-inflammatory action. Now, we are all familiar with the dose recommendations. Nevertheless, I'll just tell it once again. You can give in a dose of 12 to 15 mg every 6 hours up to 3 grams a day. The daily dose should not exceed 4 grams, and a single dose should not exceed 1 gram. And the normal dose that we generally give is 650 mg every 6 hours. It has a potential for hepatotoxicity, but it is not contraindicated in patients with liver dysfunction. You can still give it in a dose of 2 to 3 grams a day. Very safe for pediatric use in a dose of 15 mg per kg every 6 hours. Toxicity only occurs when you give more than 90 mg per kg per day. Sometimes when the oral route is not feasible, or if the patient has very, very severe pain and unable to take orally, you can give IV paracetamol infusion in a dose of 1 gram every 6 hours. We can also give it rectally, particularly in those patients who have unable to take orally, like those with oral cancers or throat cancers who are unable to swallow. You can give it even rectally. What is the NNT of paracetamol? NNT is a numbers needed to treat. In other words, it is a number of patients who receive the drug for one patient to have 50% pain relief over the next 4 to 6 hours. The lower the NNT, the more efficacious is the drug. With regard to paracetamol, the NNT is 5. That means for every 5 patients who are giving paracetamol, 1 patient will have good pain relief. It is not a very good NNT, but still it is quite all right. What are the advantages of paracetamol? First of all, it has a very good safety profile and the undesirable effects are less common, or rather uncommon. It has no effect on the gastric mucosa, so it's well tolerated with people with acid peptic disease. It does not have any adverse renal effects. It does not adversely affect the platelet function. It is tolerated by 2/3 of patients who are hypersensitive to aspirin. It also does not affect the plasma uric acid level. But there are certain drawbacks of paracetamol, and that is it has to be given every 6 hours. So increased frequency of administration. It does not have an anti-inflammatory action. So in those patients where there is associated inflammation, it may not be that good as compared to your NSAIDs. It has a potential for hepatotoxicity, but when it is given only in high doses and those with impaired liver dysfunction, and when the patients are taking more than 3 drinks a day, if the body weight is less than 50, we recommend to give only up to 2 grams of paracetamol per day. But it still can be given in patients with impaired liver function. So what is the role of paracetamol in cancer pain? It is the mainstay drug of the WHO analgesic ladder because of its safety profile and because it has an opioid sparing effect. So when you combine paracetamol with a drug like morphine, you can actually decrease the dose of morphine that you're giving. That's called an opioid sparing effect. When you add it to drugs like NSAIDs, it will improve the NNT to 2. It becomes effective. It can be also added to tramadol and opioids. So it can actually be added at every step of the ladder. Now, next we'll talk about non-steroidal anti-inflammatory drugs. Now, unlike the paracetamol, which acts on the central cyclooxygenase enzyme, NSAIDs acts at the peripheral cyclooxygenase system. So this is a very important system in the arachidonic acid cascade, which occurs after tissue injury or because of a cancer or disease. And because this is a cascade that ultimately produces your tissue and the inflammatory prostaglandins. And prostaglandins are the important intermediaries in pain and inflammation. And in fact, this prostaglandins is mediating pain through peripheral sensitization. I'll show that in my next slide. And that is how it is amplifying pain. So NSAIDs is very useful in pain, nociceptive pain, that is pain due to tissue injury, which is associated with inflammation. Now, if you look at this chart, you will see that tissue injury damage causes the release of all the tissue byproducts and inflammatory mediators like bradykinin, prostaglandins, serotonin. They form a sensitizing soup around the peripheral nerve ending or the nociceptor. And it increases the excitability and irritability of the nociceptor, which leads to amplification of the pain signal. Now, this is another example. You have the peripheral nerve, and this is the nerve ending, and this is a tissue. And when the tissue damage occurs, you have these inflammatory mediators that are released, which includes prostaglandins. Okay. And this is called peripheral sensitization. So an anti-inflammatory drug actually acts at this level and prevents the inflammation. And this peripheral sensitization depends on the extent of tissue damage. The more the tissue damage, the more the peripheral sensitization, and the more the amplification of the pain signal. Now, cyclooxygenase exists in two forms. One is COX-1, which is a constitutive or the housekeeping enzyme, which is mediating all the physiological responses of the body. It protects the stomach, the kidney, and facilitates platelet aggregation. So it is essential for our homeostatic function. But there's another COX enzyme, which is called the COX-2, which occurs only when induced when there is inflammation that has occurred. And this is the one that is causing the release of prostaglandins. Okay, so when you give a COX inhibitor, it is preventing this prostaglandin getting released, and it has an anti-inflammatory effect. So that is how it is acting, the COX-1 and COX-2. So in other words, COX-1 is the beneficial enzyme, and COX-2 is the one that is causing the adverse effects, that is the inflammation. Now, non-steroidal anti-inflammatory drugs are of two types. One is the non-selective, which is interfering with both COX-1 and COX-2, and the selective COX-2, which is interfering only with COX-2. Okay, it spares the COX-1. That means it is allowing the beneficial effects to be retained, and it's only blocking the adverse effects of pain and inflammation. So the prototypes of a non-selective NSAIDs are ibuprofen, naproxen, aspirin. Okay, they are blocking both COX-1 and COX-2. Because of the inhibition of COX-1, it exerts its adverse effects because it can cause GI bleeding, it can cause hypersensitivity reactions like bronchospasm, urticaria, it can cause adverse renal effects. But because it is blocking the COX-2, it is actually anti-inflammatory, analgesic, and antipyretic. That means the beneficial effects are occurring. So in other words, non-selective NSAIDs is a double-edged sword with both adverse effects because of blocking COX-1 and the beneficial effects because of blocking COX-2. So like I said, ibuprofen, it can be given in dose of 400 mg every 6 to 8 hours. The NNT of brufen is just 2. That means it's a good analgesic. Naproxen has an NNT of 2.7. That is also a fairly good effective analgesic. Now, because of the COX-1 inhibition, it has its adverse effects. Like I told you, it affects the homeostatic or the physiological functions of the body. It can cause gastrointestinal side effects, hypersensitivity reactions. It can cause an adverse effect on the kidney, etc. That is because of its COX-1 inhibition. Now we have the other category of drug, which is a selective COX-2 inhibitors, which is only blocking the COX-2 enzyme. The examples are etoricoxib or Nucoxia in a dose of 60, 90, or 120 mg given only once a day. So that is one good advantage of this etoricoxib. Celecoxib can be given in a dose of 100 to 200 mg twice daily. Diclofenac sodium or Voveron can be given orally or intravenously or even IM, and its NNT is 2. So this is also a COX-2 inhibitor. Now, NSAIDs can also be given topically. This has got less risk of systemic absorption and toxicity, and various drugs are available as creams and gels which contain ibuprofen, diclofenac, piroxicam, ketoprofen, etc. So the question is, are selective COX-2 inhibitors safe as compared to the non-selective inhibitors? Because of all that I had just explained to you. Now, surprisingly, where only the GIT is concerned, it is actually safe. That means it does not have an adverse effect on the GI mucosa. But where renal damage is concerned, it is as bad as a non-selective NSAIDs. On the other hand, if the major disadvantage with a selective COX-2 inhibitors is it can be prothrombotic, and there is more likelihood of myocardial infarction and stroke, particularly in high-risk patients. And it was because of this that the selective COX-2 inhibitor rofecoxib was taken off the US market in 2004 because of the incidence of myocardial infarction and stroke. And in such patients who have these risk factors, The drug of choice, if you want to give the NSAIDs of choice, it would be ibuprofen and naproxen. So the summing up the risk factors for NSAIDs toxicity, for GI toxicity, you have to be very careful in patients with advanced stage, those with history of upper GI bleed, and those with history of acid peptic disease, and those who are on all those drugs like aspirin, steroids, and anticoagulation because of the risk of bleeding. For renal toxicity, we have to be very careful about the hydration of the patient, particularly when giving NSAIDs. And also, we have to be very careful when the creatinine clearance is low. But when there are risk factors for stroke and MI, like advanced age, diabetes, hypertension, hyperlipidemia, smoking, or history of previous cerebrovascular accidents, then you must avoid the COX-2 inhibitor. Having discussed step 1 drugs, let us now switch gears and move on to step 2 drugs. Step 2 analgesic drugs are not controlled drugs. That means they are more easily available and more widely used as compared to controlled drugs like the strong opioids. So these are the weak opioids. They are given for pain of moderate intensity, which is not controlled with step 1 drugs. And sometimes we know, I mentioned, we can even skip the step 2 and directly go on to step 3. And the drugs that are used commonly, the step 2 drugs, are tramadol and tapentadol. Now coming to tramadol. It is a centrally acting synthetic weak opioid drug. Okay. But it has a dual method of action. One method is as a weak opioid, that is, it's a mu opioid receptor agonist. Because it's weak opioid, it has less tendency for respiratory depression and also addiction potential is less. The other method of action is it blocks the presynaptic reuptake of serotonin and norepinephrine. Now, these are the neurochemicals that are important in the descending inhibitory pathway of pain. Remember, the pain pathway is can be inhibited from the central nervous system downwards to the spinal cord by these chemicals, the neurochemical serotonin and norepinephrine, that can actually prevent the pain impulses from traveling up because it is a descending inhibitory pathway, and tramadol can act at this level also. So it has a dual method of action. And we are using very widely tramadol and paracetamol as a step 2 drugs. So tramadol, it has a high oral bioavailability. That means when you give it orally, it has got very good absorption, about 60 to 70%, I think. The plasma half-life is 6 hours. So you have to give it every 6 to 8 hours. The oral dose, like I said, is as potent, 1/10 as potent as morphine. So when you're giving 100 mg of tramadol, that is equivalent to, if you're giving 400 mg of tramadol, it's equivalent to 40 mg of morphine. So basically you have to divide that by 10 to know how much morphine equivalent you're giving. Now, the dose is 50 to 100 mg every 4 to 6 hours. You can go up to 400 mg. You have sustained release formulations are available, which can be given twice daily. It has some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. And there is also a risk of seizures when the total dose of tramadol exceeds 400 mg, when it is given along with drugs that lower the seizure threshold like tricyclic antidepressants and SSRIs, and also when you give it rapidly in the intravenous injection. The other step 2 drug that is commonly used is tapentadol. It is also, like I said, a weak opioid structurally related to tramadol, and like tramadol, it also has the same dual method of action. But its side effect profile could be a little better. The dose is 50 to 150 mg. You can go up to even 600 mg per day. Tapentadol per orally is equivalent to 50 mg of morphine per orally. And you can also give it as a twice daily. There are sustained release formulations that are also available. So when you want to combine analgesics to treat cancer pain, one thumb rule is never use 2 drugs of the same category. For example, we do not combine a COX-1 and a COX-2 inhibitor. We cannot combine a weak opioid with a strong opioid. But the analgesic combinations that are favorable is paracetamol NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. or NSAIDs with tramadol. Now coming to neuropathic pain. Now cancer pain, we all know, has a very strong nociceptive element because of the tissue injury. But along with this, you can also have muscle spasm. You can have associated symptoms like nausea, vomiting, constipation, anxiety, insomnia. So all that need to be treated. There can also be neuropathic pain. It may not be just nociceptive. There could be bone pain. There could be pain due to bowel obstruction. So this is where the adjuvant drugs come into use. And you can treat the other associated symptoms along with the nociceptive. So adjuvant drugs have analgesic properties, but the primary indication is not pain. For example, you're giving an antidepressant drug like amitriptyline. Its basic effect is for antidepression, but it has got very good effect in neuropathic pain. That is why it's called an adjuvant drug. It is also called co-analgesic drugs. Now, adjuvant drugs can be broadly divided into multi-purpose drugs and specific drugs. The specific adjuvants are those given for specific types of pain like neuropathic pain or bone pain or musculoskeletal pain or pain due to bowel obstruction. And they are very specific for that particular problem. But multi-purpose drugs like antidepressants, corticosteroids, sedatives, antispasmodics can be given for a wide variety of pains. Okay. Now, neuropathic pain in cancer. This can occur in as many as 40% of patients. And you can distinguish it, the neuropathic element, by its dysesthetic quality. It can be burning, shooting, electric current, or allodynia. And like I said, when you assess the pain patient, we have to see, besides assessing the severity of pain, we also have to see the type of pain. Is it nociceptive or neuropathic? Okay, and we need to distinguish between it, because if it is neuropathic, then you will have to add a drug that treats the neuropathic. Now, this is a diagram that is depicting where nociceptive. See, nociceptive is occurring at the site of tissue injury, right? But anywhere beyond this, that is in the peripheral nerve, that is a first order neuron, or in the spinal cord, or in the brain, all this will come under neuropathic pain. So the definition of neuropathic pain is it is caused by a disease or lesion in the peripheral nervous system or in the central nervous. But sometimes the cancer pain can also be mixed. It can be a combination of nociceptive and neuropathic. So neuropathic pain can be due to direct invasion or compression of the nerve by the cancer, or it can be even due to the treatment of cancer, whether it is chemotherapy-induced peripheral neuropathy, because the chemotherapy drugs, besides killing the cancer cells, can also harm the peripheral nerves. So that is called chemotherapy-induced peripheral neuropathy. It can be radiation-induced. It can be due to the excision of the tumor leading to nerve injury. It can also be present in cancer survivors for months and years, even after the treatment has been stopped. They can still suffer from neuropathic pain, very commonly seen. So you need to treat that. And the most commonly used neuropathic drugs are anticonvulsants, antidepressants, step 3 drugs like methadone and morphine, or even step 2 drugs like tramadol and tapentadol. And of course, there are other drugs also that are used for neuropathy. There is a neuropathic pain ladder. In step 1, you use either an antidepressant or an anti-epileptic. In step 2, you combine an antidepressant and an anti-epileptic. In step 3, you use an NMDA antagonist like ketamine. And in step 4, you can give a local anesthetic like IV local lignocaine. Now, anticonvulsants. This is, like I said, the first line treatment for neuropathic pain. Why is it used? Why are anticonvulsants used for neuropathic pain? Because the pathophysiology between epilepsy and pain are the same, underlying pathophysiology. In both, there is neuronal hyperexcitability, and these drugs dampen the neuronal excitability. And the commonly used drugs are GABA and pregabalin. So if you look at this presynaptic and postsynaptic neuron, gabapentinoids act by blocking this. That is the alpha-2 delta subunit of the calcium channel of the presynaptic neuron. It prevents the calcium influx into the presynaptic neuron, and thereby decreases the release of the excitatory neurotransmitters, which are aspartate and glutamate and all. And because there's less this neurotransmitters in the synapse, then there is less excitability in the postsynaptic neuron, and that is how it is decreasing the pain. So gabapentin and pregabalin, it has proven analgesic effects in neuropathic pain, tolerated very well, but it has got some side effects like excessive drowsiness, dizziness, ataxia, and all this have to be explained to the patient. Please tell them that you have to watch out for it. And for that, we basically start in low doses and go upwards. So gabapentin, like I said, you start with slow doses and you have to multiple steps to titrate the dose of gabapentin. But it is less expensive as compared to pregabalin. Pregabalin can be titrated in just 2 to 3 steps. And the oral bioavailability of this is also very good, but it is more expensive than gabapentin. Now coming to antidepressant drugs, this is again the first line treatment for neuropathic pain. The onset of actions takes to 1 to 2 weeks. And the analgesic effect is not dependent on the antidepressant effect. It occurs much earlier and at lower doses. For depression, you treat at much higher doses of these antidepressants. But because many cancer pains have depression, anxiety, and insomnia, they are very useful drugs to give in these patients. So how do they act? They inhibit the reuptake of norepinephrine and serotonin at the dorsal spinal synapses, and thus it activates the descending inhibitory pathway of pain. Now, there are 3 types of antidepressants used in cancer pain. One is the tricyclic antidepressant, which are the tertiary amines like amitriptyline, or the secondary amines like nortriptyline, or you have the serotonin norepinephrine receptor inhibitor, or the SNRI like duloxetine and venlafaxine, or you have the selective serotonin receptor inhibitor, or SSRI like escitalopram, citalopram, paroxetine. But these drugs, SSRIs, have got less analgesic effect as compared to the TCA or the SNRI. If you look at the analgesic effect, then TCA is more potent than SNRI, which is more potent than SSRI. But if you look at the side effects, the TCA has more side effects as compared to the SNRI and SSRI. So the side effects of TCAs, CNS side effects are drowsiness, mental clouding, suicidal tendency. The anticholinergic or the antimuscarinic effect of TCA include dry mouth, acute angle glaucoma, blurred vision, tachycardia, urinary retention, constipation, and orthostatic hypotension. So these are the contraindications. Avoid it in patients with conduction defects, those with prostate enlargement, and those with glaucoma. Dose administration, you start with a low dose of amitriptyline 10 mg, and every 3 to 5 days you can step it up to 50 to 100 mg. Gabapentin also you can start with 100 mg and then step it up gradually every 3 to 5 days. It can go up to 1200 or even 3000 mg per day. And then pregabalin also 75 mg, and then you can keep going up. But just remember, all these doses should be adjusted to the patient, whether the patient has comorbidities or the body weight of the patient or the renal dysfunction or the liver dysfunction. So that has to be kept in mind when you're giving these drugs. The other drugs used in neuropathic pain are ketamine. I'm running a little late. May I take 5 minutes more, Shripriya?
Yes, ma'am. Yes, ma'am. Sure.
Try to complete it. Okay. Now, ketamine is used in treating difficult neuropathic pain, and I will not go into it because we are dealing with it in the next talk, which is on difficult neuropathic pain. So I think I will skip this because I'll be taking this again in that difficult. Okay. Again, local anesthetics also will be used in the treatment of difficult neuropathic pain that are not responding to your WHO. The other drugs like anticonvulsants and antidepressants. Then you may give local anesthetics. You give it xylocaine in an infusion, IV infusion of 5 mg per kg over 1 hour. But just remember, please use Xylocard and not xylocaine, not lidocaine, because this Xylocard does not have the preservative in it, methyl paraben. Okay, so Xylocard is a drug that we are giving IV. Okay, the other drug can be given locally, but it has to be done in a daycare setting with cardiac monitoring. Now, topical local anesthetic patches are also available. 5% lidocaine patches are now available in India, and we can apply it in cases of neuropathic pain. Now, corticosteroids, I said, is a multi-purpose adjuvant drug. It can be used for a variety of cancer pains. That is why it's called a multi-purpose drug. It can be used in neuropathic pain, bone pain, headache because of secondaries in the brain, arthralgia, pain from obstruction of hollow viscous, or pain due to spinal metastasis. So dexamethasone is very advantageous because of its long duration of action. It has a half-life of 36 to 54 hours. So you give it only once a day, and it has got less mineralocorticoid effects, so less chances of fluid and sodium retention. But you always give steroids in the morning because it can cause insomnia. You can also give GABA agonists like baclofen, which is an analog of the inhibitory neurotransmitter GABA, and it's given in those neuropathic pain patients with spasticity. Okay. Bone pain is because of the metastatic bone disease, and it causes what is called skeletal related events, fractures or edema and swelling and etc. So this can be very agonizing and it can affect the quality of life of patients. So the variety of drugs that can be given for bone pain include starting with corticosteroids and NSAIDs. Calcitonin used to be given, but the latest review shows that there's no significant improvement in quality of life. But the drugs that are preferred are the bisphosphonates and denosumab because they inhibit the bone resorption mediated by the osteoclasts and reduce the SREs. And it also palliative radiation can be used. Now, bisphosphonates are very useful in treatment of intractable metastatic bone pain. It acts, like I said, by blocking the osteoclastic activity and bone resorption. Zoledronic drug acid is given in a dose of 4 mg IV over 15 minutes every 4 weeks for 1 year. The side effects of zoledronic acid include pyrexia, renal dysfunction, hypocalcemia, and a dreaded complication called osteonecrosis of the jaw. So when you want to compare the drugs that are used for bone pain, that is zoledronic, which is a bisphosphonate, and denosumab, which is a human monoclonal antibody, you find that this is more cost effective. This can be given IV. It has more risk of renal toxicity, but less risk of hypocalcemia. Whereas denosumab can be given subcutaneous with less risk of renal toxicity, but more risk of hypocalcemia. And it is superior as compared to zoledronic acid, preventing and delaying the skeletal-related events with a better median survival rate. Now, palliative radiation of the bone is also widely used for treating bone pain and bone metastasis. These are the nucleotides, strontium and samarium, which delivers radiation to this bone mets. It can cause good pain relief, preserves the function of the patient, bone function, maintains a skeletal integrity, and less risk of serious side effects. But the drawback is it takes several weeks for the pain relief to come. Pain due to bowel obstruction can be treated using steroids, octreotide, and anticholinergic drugs. These all act by decreasing the intraduodenal secretions in the gut and decreasing the peristaltic movement and thus reducing the symptoms of bowel obstruction. The other adjuvant drugs that are skeletal muscle relaxants or neurolepts, particularly when the patient has got delirium and agitation. You can also add sedatives, anxiolytics, laxatives, or even antibiotics if there's an infection. So coming back to our case scenario. To recapitulate, this was a 35-year-old father of 2 who had this pain, which was a gnawing pain in the right shoulder with the burning and tingling in the right arm. He was unable to sleep. His NRS was 4 in the day and 6 at night. He also looked very depressed and dejected. This is the body language of this patient. By looking at him, you can make out that he is depressed. So the points to be considered in this patient are the intensity of pain. Intensity is mild to moderate, okay, based on the NRS score. The type of pain, it is both nociceptive and neuropathic. Neuropathic because he had that burning along the arm also. The temporal nature of pain, it was worse at night. And the unveiling the meaning of pain, that is whether there were functional, emotional, social, and financial concerns. Yes, he was unable to sleep. He was unable to work. He had emotional pain because he was a father of 2 young kids with possible financial and social concerns and psychological concerns as well. So to begin with, we can start with step 1 drugs, but if it is not resolving, we may go up to step 2 drugs also. So you can give a combination of paracetamol with NSAIDs, but because his pain was more at night, you can give a sustained release preparation at night, like paracetamol 1000 mg or diclofenac SR 100 mg. Okay, so that will tide over the night. You can also add an anticonvulsant and antidepressant drug for the neuropathic pain. We can give a adjuvant drug like a sedative so that he gets a good sleep, and also it can help in allaying his anxiety. And very importantly, we have to address his psychosocial concerns as well. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. Its advantages is the simplicity and easy implementation, can be used the world over, and it has legitimized the use of opioids in cancer and non-cancer pain. So I think I will stop here. Okay.
Thank you, ma'am. Thank you so much for the presentation. We can take up a few questions. We have, you didn't take much time. I mean, you didn't overshoot the time.
Sorry, I think
No,
the
no.
beginning that thing glitch was there where the speakers were concerned.
No, but
I'm
you
sorry
ended
about that.
perfectly on time. Yes, Dr. Nithi. Can you unmute? We can't hear you.
Can you hear me now?
Yes, yes.
Yeah. Thank you, ma'am, for your talk. I just had one doubt, ma'am. Like, how much time do we wait to, move up the ladder in deciding that the pain relief is not inadequate with whatever drug of choice we have chosen, both for nociceptive and neuropathic pain? Like,
See, like where nociceptive pain is concerned, you don't really want the patient to say that we have to wait and things like that, right? You can make out in within 24 to 48 hours whether he's responding or not. And then if he's not responding, rather than him suffering from pain, I think it would be better to move up the ladder. But when neuropathic pain is concerned, like I said, antidepressants take a week or two for it to start working, actually. Antidepressant for neuropathic pain. And so that can be titrated more slowly, not recommended to increase a dose less than 3 to 5 days.
okay.
But when nociceptive pain is concerned, and the patient is really having pain that is not responding to it, you can go up the ladder in even 24 hours. Sri Devi, what do you think? What is it? I mean, you have any inputs on that?
Same, ma'am. Same. What you said. It's the same.
So, shall I stop the screen share?
Yes,
Then
yes.
then I can go on to my full view. Correct.
Yes. So there is a comment by Dr. Ravi. There is an article recently where tapentadol escalated to step 3 drug.
Okay, I didn't know about that.
I think from my experience in using tapentadol, it is somewhere between the step 2 and the step 3. It is not really like a tramadol, but it is not really like morphine. So it's somewhere between step 2 and 3, but I am not aware of a formal inclusion of tapentadol into step 3, not yet.
Similar to tapentadol because of its dual method of action.
Yes.
That it acts as a weak opioid as well as a inhibitor of the reuptake of serotonin and all. It acts on the descending inhibitory pathway. That's a similarity between them. Once it is elevated to the status of step 3, then it will come under the narcotics purview, right? Then maybe you will have to have a special prescription form for that. I'm not sure about it. We may look it up and see.
Sorry.
Hello.
Yes.
Ma'am, like we have patients of CA breast on follow-up, like 3, 4, 5 years they are coming, and most of those patients complained of pain in like burning or needles and prick sensation, like neuropathic pain at the site of MRM. And we usually prescribe gabapentin for that, or the combination like gabapentin or nortriptyline. And still like most of the times, every time patient comes for follow-up and they complain of the same kind of pain. So I wanted to know about that.
So if it is not responding to the neuropathic drugs, like it depends on how much have you escalated it to. Like you can give a combination of antidepressant and an anticonvulsant as well. Okay.
Yes, ma'am. Yes,
Like I
ma'am.
said, you can combine the two also if it is not responding to the first line treatment.
Yes,
The
ma'am.
combination of the two. So you may have to combine the two. But it's very important to also see the patient, examine the patient. If the patient has undergone an MRM, is there muscle tightness around? You know, the pectoralis muscles or the deltoid muscles or the muscles around the chest, are they also pulling? You know, you won't believe it. Muscle tightness and muscle shortening can worsen neuropathic pain. It's a phenomenon called myoneuropathy. It's not neuropathy alone, it is myoneuropathy. This is a new concept that is coming up. I have seen patients who have such severe pain, but you find that pectoralis muscle, you know, that is pulling here, you know, or the other serratus anterior, whatever it is, you know, the muscles of the upper chest and the arm,
Yes.
which are so tight that the patient even cannot move their hand, you know.
Yes, ma'am.
And that tight muscles, believe me, can also cause nerve compression. Okay. So whether it's tight muscles in the breast or whether it's a tight muscle in the spine or whether it's a tight muscles around the back of the neck, it can cause cancer pain or non-cancer pain. Tight muscles can cause compression of nerves leading to a phenomenon called myoneuropathy. Okay. How do you treat that? Muscle relaxants are not the best drugs to treat that kind of pain, because when you give muscle relaxants, you can only go up to a certain limit and it will cause muscle relaxation all over the body, which you don't want. So what I do is I do dry needling of these muscles. Okay, dry needling is like acupuncture needles that can be put into the muscles and relax the muscles.
Okay.
Very useful in treating all your shoulder pains, neck pains, headaches, cervicogenic headache, low back pain, and also pain due to breast cancer. But only thing, you have to be very careful when you're putting it here in the upper chest, because then you have to use ultrasound guidance so that you do not go deep and you do not injure the pleura. Okay. But if you have to use it on the upper arm or in the superficial muscles, you can do it even without ultrasound guidance, provided you know your anatomy well. But that it will be really beneficial in those patients who are still not responding to anticonvulsant or antidepressant.
Okay. Ma'am, I have one more question.
Yeah.
Ma'am, when we are prescribing these pain medications, so the prescription list usually goes very long, and the education status of most of the patients is not that good that they would be able to understand every drug we prescribe, because it's not only the pain medications we are prescribing, it's many other medications we prescribe along with that. So something regarding that.
Basically, your prescription has to be simple, right, to make everyone
Yes,
understand. And if you can, do it graphically, like what
ma'am.
I do is I put in the place of a tablet, I put a 0, like in the morning 0, then
Uh,
into afternoon and night 0. So then they know that they have to
uh,
take it in the morning and in the night. That's a very simple
Ma'am,
way of.
agreed. That is what we are also doing. But what I feel many a times, like the list, like we are prescribing. Suppose we have prescribed one opioid, one analgesic, like NSAID, or one adjuvant, and there will be like 3, 4 more other drugs with that. So many a times, what I have, like, we usually ask the patient to come, and then we prescribe it over their tablets also, but the understanding level sometimes is not that good of that patient. So
Maybe you
uh,
can
you
categorize
know
the analgesic drug separately. This is for pain, this is for your bowel, or this is for your the cancer per se. So if you can put it in different things, like they'll understand, okay, this is what I have to take for pain, this is for my acidity problem, you can explain that, categorize
Okay.
thing rather than making the whole thing into one big bundle. And Sridevi, if you don't mind, I just want to tell something. I just, last week, I was in IGMC, where Shilpa comes from.
Okay.
I
Okay,
had
ma'am.
gone to Shimla for a holiday, and my brother-in-law broke his leg and fractured his tibia. And I went to IGMC because closest place, and I must compliment the good service that we got in IGMC.
Thank you
They
so
did an
much.
excellent job of doing the X-ray and putting a temporary cast, and then we could drive down from there. And so I just wanted to, I'm sorry I took a minute, but when I
No,
saw that she's from IGMC, I had to compliment that hospital.
thank you so much,
Orthopedic
ma'am.
team
Like
was excellent, and I'm
like
really appreciative of that.
thank you so much, ma'am, for the appreciation.
Dr. Anubha, you had a question.
Anuba?
No, Anubha, we are not able to hear you. I think, yeah. No, no. You are unmuted, but we can't hear you. No, no, Anubha, we can't hear you. So I'll just take one question from the chat. What if the patient has constipation? What is the preferred analgesics? What are the preferred analgesics if patient is having constipation?
See, the drugs, like most of these neuropathic medications, like the TCAs, and they can cause constipation. Okay. And so we have to be careful. Maybe we can give a laxative along with it if necessary. But otherwise, paracetamol and NSAIDs and all, they don't cause anything. Even gabapentin and pregabalin don't cause constipation. It's basically the antidepressants that can have among these drugs. Of course, strong opioids are totally different. I think tramadol also can cause constipation, Sridevi.
Yes, yes, we do prescribe laxatives along with tramadol.
Yeah. So we have to proactively prescribe laxatives in those with constipation.
Ma'am, I think Dr. Anubha's question is on lidocaine patches. When in the treatment protocol would you consider patches? I think you are covering that in the difficult pain
Pain
session.
will be
Will that
talking.
be okay, Dr. Anubha? We are covering that in the difficult pain session taken by Dr. Mehdi. And there was a question on TENS again that she's touching upon TENS again in that session, how it works. And all.
See, all these things like TENS and all, they are what would you say? They are they can be given, and they can supplement the analgesia. Okay, so it is like whenever you give any treatment, I would like it to be a multimodal kind of a treatment. There's nothing like giving drugs alone. There is pharmacological and non-pharmacological treatment of pain. Okay, I'll be talking about it then, but just to say that pharmacological, we know the interventions that can be done, the pain interventions, but there's a non-pharmacological way of treating pain, which includes the psychological therapy, the physical therapy, the maybe alternate therapy or complementary therapy, homeopathy, Ayurveda, anything. So physical therapy plays a very important role. So all of them, it has to be a multi-pronged approach when you treat a patient with cancer. There is no magic bullet to treat cancer, like no particular drug or no particular intervention. It has to be a dry needling. That's another way of treating pain. So these are all the multi-pronged approach. So definitely TENS and all do play a role in treating.
Ma'am, there's a question on the follow-up. How frequent should be the follow-up, especially when you see a new patient? How
It all
frequently?
depends upon the patient's condition. I'm talking of WHO analgesic 1 and 2. Okay, that is mild to moderate pain. So we can follow them after 1 week also. Or what I do is I always give my telephone number to the patient. I'll say that I have seen you once. Now, if you have any problem, please give me a call. As simple as that. Because sometimes these patients are so difficult to bring, to the hospital. But once you have seen a patient, you have a mental picture of the patient, then even on a telephone call or even if the caregiver comes, you can still titrate the medicines. or you can do a video call with the patient anytime. So, but if mild to moderate pain, I think 1 week or 2 weeks is more than enough, I think. And the rest can be titrated on telephone. I think.
Ma'am, maybe two quick questions before the case presentation. Role of cannabis oil, which is used in Ayurveda, at which step can we consider?
Which cannabinoid?
Cannabis oil, which is used in Ayurveda.
I have no idea.
I don't know.
I think it can be used, if the patient always these Ayurveda and all can be alternate therapy in treating pain. I believe there's a role in alternate therapy.
But I don't think that's literally placed somewhere in the ladder. According to the ladder, it doesn't come under the ladder.
When you can add it,
if that's
like
a
an
question.
adjuvant, yeah.
Yeah.
Hello, ma'am.
Dr. Shetty? Yes.
Yeah, ma'am, I'm Dr. Shetty. Now, since we are discussing about the minor pain and moderate pain, I have a patient. She's about 45 years old. She's she's diagnosed with the CS cervix first stage, but she doesn't have any general symptoms at all. She's all right. The main problem is localized irritation. So for that, whether we should give generalized medicine, like general medicine or some topical ointment, what do you prefer, madam?
But if
So
she is
just
only local
Yes.
irritation, is it?
Local irritation, cervical area. Now for last 1 month, otherwise she's quite a happy lady, but I cannot, I'm like trying with all minor and moderate medicines, but even then I'm not able to persuade her. So I usually like some topical ointment also I provide her, but with that also she is not able to. So whether do I like beyond this lignocaine topical ointment, anything else do we have, like
I don't know, but I think the gynecologist will be the best person to tell
No,
that.
this is the outside only, ma'am. Usually I see the patient, she comes in the clinic.
Ah.
And that irritation, some minor irritation on the outside of the vagina, like,
It could be a neuropathic. Does it have a dysesthetic quality? Like
no, nothing. She's always coming with that localized irritation, nothing else. No pain at all.
no pain, no?
No
Because
pain, no
if
pain.
it is abnormal sensation, is it abnormal sensation?
No, she's saying like some irritation that is disturbing her. Otherwise, no discharge, nothing. Like it was early diagnosed case. So how we'll be able to manage?
Could be a neuropathic. Could be. I'm not saying I've not seen the patient, but I have patients who complain of dysesthesia in the perineal area.
Okay.
Not be frank vulvodynia, but it could be just dysesthesia. They respond to neuropathic medicines.
Okay, so that oral
Start on a small, start on a small dose of tryptamol.
Okay,
that could help.
we can try with that. No problem.
It's a it's not normal. It's a different kind of feeling. So whether that is irritation or dysesthesia, I don't know.
We also don't know, but I just want to since I got the opportunity, I thought I would discuss with you.
There's no harm in giving her a small dose of.
Ma'am, if you permit, can I comment on this? Ma'am, if it's a case of CA cervix, ma'am, and it's a post-radiation, estradiol creams actually give a lot of benefit, ma'am, post-radiation. We are using it actually. In post-radiation patients, if we use estradiol creams, it gives a lot of
estradiol, yeah.
Estradiol, okay. Thank you, doctor. I will try for that.
Yeah.
Thank you.
Thank you.
Dr. Aditi, you had a question. Maybe after that, we'll start the case presenting.
Yes, ma'am. My question is again to what I had put it in chat. Coming to this cannabis oil, why was I asking for the ladder? Because we have always told that we should not be giving two opioids. So that was my reason that, if we are giving any oral, can we still give cannabis oil or no? That was the confusion that I was having about it.
Devi, would you like to take that?
Yeah, we had a few instances of patients coming with, this kind of, they were already on cannabis from somewhere, and then we had to start them opioids.
Ma'am, I'm a family physician. My corresponding Ayurvedic doctors, they easily prescribe cannabis oil. So it's quite frequently used as such. So that is why I was a little confused.
Yeah, I tell them if they feel it is beneficial, they can continue using it. I'm slightly worried about the when I prescribe opioids, like how will I titrate?
That is the confusion I'm
so I tell them
tramadol also.
Yeah, so I tell them that I don't know anything about cannabis. I don't know the mechanism. I don't know how it acts, the pharmacology or anything. But I know very well about the drug which I am prescribing. So I know which side effect is what. So I tell them, if you think that is beneficial, you can continue, but I can deal only with the opioid part of it. So I frankly tell them I don't know anything about cannabis. I have had these kind of patients. But when you titrate, you just get confused. Sometimes they become too drowsy, so we don't know whether it is opioid or the cannabis causing the drowsiness. So we can play with our medication, but I just don't touch the other one.
Thank you so much.
Shall we move on to the presentation? And we have a few more questions. We'll take it up after the presentation. Shripriya?
Yes, ma'am. Sharing this.
Yes, Dr. Shilpa. Over to you.
Okay, thank you, ma'am. Myself, Dr. Shilpa, working as SR, Department of Radiotherapy, IGMC Shimla. Today is the case of 50 years old female patient of CA cervix who has recurrent disease. She presented with complaints of pain in abdomen and low backache, and there was history of bleeding per vaginum on and off. History of illness. She was registered in our department in August 2020 with complaints of postcoital bleeding and discharge PV for 8 months, para 2 plus 0 and postmenopausal for 1 year. She was diagnosed with a stage 3B CA cervix, moderately differentiated squamous cell carcinoma. She was treated with radical CRT to pelvis with weekly injection cisplatin. And thereafter, she was not fit for intracavitary brachytherapy. And then she was given supplementary CRT. And the treatment was completed in November 2020. Patient was kept on close monthly follow-up in view of minimum residual disease over cervix on first follow-up. And then she was started on palliative chemotherapy in March 2021. Then after completing her chemotherapy, she underwent surgery. Total abdominal hysterectomy with bilateral salpingo-oophorectomy was done in August 2021. Per op finding, there was no evidence of disease, and even on detailed histopathology, there was no residual tumor. Then patient was kept on follow-up. In January 2022, patient had complained of dull aching pain in abdomen and lower back, which was continuous, and pain score was 6. And there was history of bleeding per vagina, which was on and off. On examination, there was pallor was present per abdomen. It was NAD, and on PSPV examination, ulcerative lesion was palpated over the vault. Biopsy was sent, which came out to be descriptive. The patient was admitted and 2 units PRBCs were transfused. CCT abdomen and pelvis was done. There was heterogeneously enhancing mass was seen posterior to urinary bladder, which was infiltrating into urinary bladder and rectosigmoid junction and left distal ureter, causing gross left hydronephrosis. And overall, it was suggestive of residual mass along with pelvic and para-aortic lymphadenopathy. Then the patient was started on pain medications as well as palliative chemotherapy based on injection paclitaxel and carboplatin. Psychosocial aspects, the patient belongs to a far-flung area, and there is non-availability of basic medical services near her home, and traveling long distances for her treatment. And the patient was depressed because of the continuous treatment for more than a year and still not being able to be completely cured. And there were some financial concerns, like the treatment cost is covered under the Ayushman Bharat scheme. Though while she's traveling long distances, the stay while she's coming attending the OPDs, the stay that also was a concern. Medications, injection tramadol 50 milligram intramuscular was given for immediate relief, and then she was started on tablet tramadol 50 milligrams TDS and tablet gabapentin and nortriptyline in the doses of 400 milligrams and 10 milligrams respectively was started HS. And for in case of nausea or vomiting, she was prescribed tablet metoclopramide 10 milligrams TDS and tablet bisacodyl 10 milligram HS in case of constipation. Her main concern was pain, bleeding, and the recurrent disease despite being compliant. Summary, radically treated patient of CS cervix with recurrent disease with pain and bleeding per vaginum. Discussion points, addressing all the aspects of pain in this patient is important. Also addressing the psychosocial issues and the role of counseling while prescribing pain medications. Thank you.
Thank you, Dr. Shilpa. Thank you so much for the very comprehensive presentation and the discussion points. So participants can comment on this. And after that, we'll go back to Dr. Mary and ask what is her thoughts about it. Anyone would like to comment or type in the chat, please? Dr. Shilpa, what is the current status of pain for her, like in terms of numerical rating scale?
Ma'am, she was, ma'am, relieved. Like even today, I talked to that patient again before this thing. So she was like that the pain is no more there, and the pain relief was like I was happy with that. The answer, the way she answered for her pain, the initially when I saw that patient, and now she's is completely relieved as of now.
So that means the patient is in ladder 2 treatment, no? Is
yes, ma'am.
Okay.
Yeah.
Just based on the session that we had last day, it will be good to have this pain scores before and after. So when they say good relief, you will understand how far.
Yeah.
And it is very clear for us also, like what was the pain score and how she responded.
Definitely,
It's easier for us to learn also. And that will be a good practice. If another doctor comes and sees your chart, it's very clear that how much difference you made in terms of score.
Yeah, actually, ma'am, today I could talk telephonically to the attendant only. So, yeah.
No, just as a reminder.
Okay. Yeah. Yes, ma'am. Sure, ma'am. Sure.
So whether while presenting, we can present the way that the patient is under ladder 2 treatment?
That is not needed, ma'am. We just need to know the details of pain.
Not the pain.
When you're
pain
talking
intensity.
about pain
Intensity.
the
Okay.
PQRSTU,
Yeah,
then you will
sure.
understand where exactly. So
yeah, that
people who are listening will get a clear idea about what kind of pain, what is the
That's true.
intensity. Thank you so much. Ma'am, Mary ma'am, I think we have only few minutes left, so I think I'll just come back. Yeah.
Talking, we have to now talk in terms of total pain management, right? We have talked about the physical pain, but like, in total pain, there is a psychological pain, there is a social pain, and there's an spiritual pain as well. So when we talk of pain, let us not only concentrate on the physical part of it. Like we have treated the physical pain, that's fine, but she may be feeling so many other problems. She has social problems. She may be feeling psychologically depressed, so she has got psychological pain also. Okay, so let us look at it from the view of total pain of the patient. Whenever we see a patient, physical is just one part of that pain that they're complaining of. But till you treat everything else, she may be even having spiritual issues, that why is this happened to me? What have I done wrong? Is it a punishment for what I've done in the past? So these things also need to be allayed. Does she have good support from her husband? What are her children doing? So, I mean, maybe we cannot address a lot, but by just listening to them, it can make a lot of difference that they know that you're empathetic with them. The patient may be in stage 3, stage 4, but if you have an empathetic person listening to you, it will make a world of difference. So I always say that physical is just one part of that pain. You have to look at the other causes of pain as well, which this lady has. At 50 years, she must be going through having young children also. So we have to listen to them, lend a listening ear to these patients, and try to see whether we can address those concerns as well. Maybe giving an antidepressant may help, maybe she's depressed, she's anxious, she's fearful of the future. Okay, so all these things also have to be addressed along with the physical. But I think the fact that she's controlled her pain, that's good. That means she's controlled with step 2 drugs. But like Sri Devi said, if you put a pain score to it, and we know that earlier her pain was 5 out of 10, and now it has become 2 out of 10, then when you document it, it will become, you know the trend, and also anybody else looking at the file also will know, even if you're not there. So it's always good to put a number or the rating of the pain score as well.
Yes, Dr. Shweta.
Yeah. So I'd like to ask if is there any role of the patient when they're literate maintaining a diary for pain? It's just, I mean, apart from us starting it, could we also ask?
I think that's not a very good idea. I mean, I don't know. Maybe that will, they will focus too much on their pain. So I don't think, that it will make them feel, I mean, I don't think it's a very good idea to patient to chart their pain. I think it should be assessed by either a nurse or a doctor.
No,
because they will focus so much on themselves, it be causing like what is called somatization. They'll be always focusing where is the pain, how much is it, and that can cause more pain also, so it's called somatization. So I don't think it's a very good idea for the patient to chart their pain. In fact, we should tell them to take their mind off the pain. That will be a better, it's called distraction. That will be a better technique rather than psychologically, it may not be good for the patient.
Thank you.
Shweta?
Ma'am, I just wanted to ask, suppose, I mean, if her pain has gone down on the NRS, then should the drugs also be pulled down to a step 1, or should the patient continue on tramadol only?
I think now we should not, lose the gains that we have had. Okay. And we don't want the patient to go back to pain, right?
Okay.
So that will again create a, it will demoralize the patient also. And if they're tolerating tramadol well and they're having good control, see, the disease is the same. Disease is not in any way coming down. So it's very unlikely, unless there's something, a cure happens, it's very unlikely that the pain will come down. If you de-escalate the dose, and tramadol is quite safe to give to these patients with not much effect on the kidney or the liver, unless of course a patient has got severe renal or severe liver dysfunction. So I think it is safe drug, and rather than demoralizing the patient, in view of the fact that the disease is still there, maybe it's not a wise idea to de-escalate at the moment.
Okay. Thank you.
Yes, Dr. Nishant.
Ma'am, my question is again with respect to de-escalation, ma'am. If the patient is on morphine 10 to 15 mg 4th hourly, and we have got reasonable pain control after probably 4 to 5 days, is it a good idea to reduce the morphine doses with and without drowsiness, ma'am? In both cases, I would want to understand how to de-escalate morphine doses if the patient is drowsy and if he is not drowsy. Or is there any role of de-escalation of morphine?
If the patient is drowsy, definitely you need to de-escalate the morphine. Okay. Or if the patient has got other CNS signs, then you need to de-escalate it. No, that's called toxicity.
All right, ma'am. So how do we do that, ma'am? So if it is 15 mg 4th hourly, so how soon we should taper it, and how to do it exactly?
I think Sri Devi, you can take that call.
Yes, we have a next session is on opioids. So we have a lot of case scenarios and discussions in the coming session by Dr. Sunil. We'll be discussing in detail about dose titration and de-escalation, withdrawal, and everything in detail.
All right.
I was just answering some of the questions in the chat. Dr. Ravi was asking about what are the non-pharmacological methods to deal pain in this patient. I just started typing, but ma'am, please add on to that. I was just telling that I'll start by listening first. What he has to tell. Shripriya, someone's mic is.
Sorry, ma'am. Sorry.
So yeah, so I was just telling that first of all, I'll start by listening what she has to tell about her issues. We may not be having answers to everything. If she asks you why God has given this to me, I can't say no, no, don't think like that. So I'll just be starting with listening to that, and then I will list out few things which can be covered, and I'll involve the team, multidisciplinary team, my nurses and social workers. So they'll have to play their part where they have to give the counseling wherever it is needed, empowering the patient and the family if there is a possibility of rehabilitation. As mentioned somewhere in the presentation, she had problems in going to hospital due to the financial issues. I'll ask, is there any volunteer who can just give a ride or sponsor a ride to the hospital? I'll ask the community people whether they can just help with the transport so that the transport is taken care of. And bringing in realistic goals, what can be achieved in a real scenario. I can give you pain relief. These are the things 1, 2, 3, 4 which can be done, but this will take time. This will not happen in one sitting. It will take time. Now that Dr. Shilpa's patient has less pain, I think now you kind of have a good opening or good rapport with the patient. They'll come and talk to you more, hopefully. So one by one, you will be able to understand what she is thinking. What we might be anticipating will be very different from what they might be going through. So it's a good thing to start with listening, and then list down things what can be done, and then come into a plan. That's what I wanted to convey. Madam, anything from your side?
I think that's a good way of putting it, because now she has got confidence that pain has got relieved, so she and the fact that she's telephoning and things like that, they know that they have got people who are empathetic with them, and that will even make them open up also about their other problems. See, unless you establish a rapport, no one will communicate, believe me. They all will think that this doctor is not concerned, he's only bothered about see, we have to treat the patient, not the disease. That is one very important thing, particularly in cancer, in any patient. It is not the disease. We have to focus on the person rather than the disease. So even if we cannot cure the patient, we can care for the patient. That is, Pallium as one of its main principles is that only. You may not be able to cure a patient, but you can definitely care for a patient. So always treat the person rather than the disease. They may be having terminal cancer, but the fact that you are listening to them and empathetic to them, it makes a world of difference, and they get the confidence in you. And particularly since some amount of pain control has been got, they are even more confident that this doctor can, help me out in this situation.
Thank you so much. Shipri, we can stop screen sharing. Thank you so much, everyone, for the interaction. Because without interaction, this would have been a very dry session, all the sessions. So please keep up this interaction till the end of this program. And there were many questions, especially on opioids and on bowel obstruction, TENS. We will be covering definitely that in the coming sessions. If I have not asked these questions during that session, please remind me to ask about the questions you have asked. Thank you so much, ma'am, again for the wonderful session and the discussion and the answers that you have given to everyone. Thank you so much, all the participants, for the interaction and for giving your time to learn palliative care. Shripriya?
Thank you, Dr. Sridevi. Thank you, Dr. Mary, for your wonderful time as always. This was an enlightening session, I believe. Thank you so much for your time. And we believe that all the participants might have got a little bit more idea about the management of pain, which we'll be developing in the coming sessions. So with that note, this is Sripriya along with Dr. Mary Abraham and Dr. Sridevi signing off from the Tips Echo Hub. Stay tuned, stay connected for more interesting sessions and eminent faculty discussions. Till then, take care. Bye-bye.